Thank you. I just want to also indicate that I'm an ex-labor and delivery nurse, a prior childbirth educator, and I've personally had 7 pregnancies. I have 2 lovely daughters. Not all of my pregnancies were successful. And for many years, I wanted to be a midwife when I grew up, but then discovered much to my chagrin that I was really kind of a witch in the middle of the night. And so in deference to my potential patients, I trained for a job that I could do during daylight hours, and that is as an adult nurse practitioner. Okay, let me see. Why is this there? This is my conflict of interest slide. As you can see, I have no known conflicts of interest. The opinions expressed during this presentation are those of the presenter and are not necessarily those of my professional organization, institution, or workplace. Let me start out with a true story. Michelle was 22 years old and working for a private ambulance service as an emergency medical technician. It was her dream job. And then she became pregnant. At one of her prenatal visits, her obstetrician recommended that she not lift over 50 pounds. As an EMT, she was required regularly to lift patients in stretchers that exceeded that weight, so she asked her employer for a temporary assignment. She had noted that there were several postings for dispatcher jobs that did not require any lifting at all. The company already had policies in place that gave light duty or modified duty job assignments to EMTs who had become injured. But her manager told her those jobs were for injured EMTs and not for people that were pregnant. And her only option was to ignore her doctor's advice or take a leave of absence for 90 days. After that, if she didn't come back, she'd be fired. Michelle was stunned. She was 6 months away from her delivery date, and she was looking at having to live for 6 months without a paycheck. She took the forced leave. Even with help from her family and some friends, she had to sell her car and give up her apartment. She also amassed significant credit card debt, paying for essentials for her son, medical bills, and repaying the loans for EMT training. And in the past, this was not really an unusual scenario. So up here on the slide are the objectives of the presentation. And at the end of this presentation, I'm hoping that participants will have a basic understanding of some of the major physiological changes in pregnancy, be able to identify some of the major hazardous physical and chemical exposures during pregnancy that are known to result in adverse outcomes, understand the requirements of the old and new 2023 legislation regulating work actions related to pregnancy, childbirth, and the postpartum period, and in particular, the Pregnant Workers Fairness Act, or PWFA, and the PUMP Act, and finally, list some appropriate accommodations for the pregnant or breastfeeding worker. Now, pregnancy is a fascinating and complex physiologic state. It's constantly changing and puts unique stresses on the childbearing individual. Many of these changes can directly or indirectly impact work. And in the next few slides, I'll briefly discuss the interaction between work and the pregnant worker. Let me start out by stating that if an individual can do a job before pregnancy, in most cases, it is entirely reasonable to assume that an individual can do that same job both during and after pregnancy. All of us have known pregnant superwomen. Early in my nursing career, I worked on an orthopedic floor, and with a tiny woman, she must have not weighed more than 100 pounds, and she was pregnant with twins. That woman worked until 2 hours before she delivered. She was lifting, moving patients, running up and down the nursing floor, and putting us all to shame. And she delivered 2 normal babies on her due date. And there are people like that. Others will not be that healthy and amazing and may be working in jobs where physical and toxic exposures could indeed affect the outcome of a pregnancy. Pregnancy may also lower the seizure threshold. Women with underlying seizure disorders may find the frequency of their seizures increases due to a drug plasma level decline. Epileptic individuals can have successful pregnancies, but the risk of a poor outcome are much higher. These women may need enhanced folic acid supplementation, monthly monitoring of treatment levels, and amniocentesis at 16 to 18 weeks to detect neural tube defects. Women with other pre-existing chronic diseases, for example, diabetes and lupus, may need more frequent doctor visits and more time during the workday to manage their conditions. They may also need more breaks for water and snacks. So there are some major exceptions to the first statement that I made. If a job entails any of the hazards listed on this slide known to potentially have adverse effects on a fetus, it makes sense to err on the side of a healthy baby. So as early as 1984, the American Medical Association produced this table with recommendations relating to lifting and other tasks in pregnancy. They recommended some tasks be eliminated or limited at a certain stage of pregnancy. As you can see, prolonged standing for more than 4 hours should be avoided after 24 weeks. Climbing should be avoided after 20 to 28 weeks, and repetitive lifting of over 50 pounds is not advised after 30 weeks. Even repetitive stair climbing should be limited after 28 weeks. Now, the National Institute of Occupational Safety and Health, or NIOSH, created this algorithm based on evidence. It's a bit complicated, but if the pregnant individual answers all the questions in the yellow boxes and determines her gestational stage, this offers some guidance regarding what NIOSH calls recommended weight limits, or RWLs. NIOSH has incorporated how many hours per day the pregnant woman is expected to lift in determining RWLs. Their recommendations are based on relatively old research studies indicated at the bottom. It's important to note that both AMA and NIOSH recommendations are based on the presence of a normal pregnancy in a basically healthy person. Now let's talk about the physiologic changes a pregnant body undergoes. There are cardiovascular changes, pulmonary, metabolic, gastrointestinal, immunologic, skin, renal, visual, psychological, and pharmacokinetic alterations. We'll discuss each of these physiologic transitions in the next few slides. To the right of this slide is my older daughter, my son-in-law, and their firstborn. Theirs was a totally normal pregnancy until the end, when they discovered the baby was breech with the cord wrapped around her neck. After it was determined that the baby couldn't be safely turned, a cesarean section was performed. It's always good to remember that in pregnancy, the unexpected can occur at any time because so many bodily systems are affected. I'll defer discussing all the endocrine changes related to pregnancy in detail because this would require several additional lectures, but we'll touch on a few endocrine issues within other sections. Just keep in mind, the changes are, in a word, massive. Now, cardiac output is generally increased in pregnancy, sometimes even up to 45% of normal. Stroke volume is up, plasma volume is up, and the heart at the end of pregnancy is displaced upward and to the left. Heart sounds in a pregnant woman can change as well, with the first heart sound louder, a wider physiologic split, and often a third heart sound. Pregnant women may exhibit new onset systolic flow murmurs. There is so much going on with the heart. These are generally normal findings. However, with women with underlying heart disease, major changes from baseline should be carefully evaluated. It is important to note that toward the end of pregnancy, a pregnant woman mechanic or plumber may have difficulty lying supine to do their work, that is, on their back, because of a risk of supine hypotension due to the pressure of the uterus on the great vessels. She also might have difficulty squeezing into tight places or under a car for obvious reasons. There are significant pulmonary changes as well. Although the basal respiratory rate does not change, both tidal volume and minute volume increase drastically. This is one of the reasons pregnant women should be protected from respiratory toxins. They take in more toxin with each breath and metabolize it rapidly. Functional residual volume is lower due to the upward pressure on the diaphragm from the enlarging uterus. Due to the fact that pregnant women consume oxygen at 20% higher rate means that they would be much more sensitive to changes in elevation and oxygen deficient environments. FEV1 does not change, but 70% of pregnant persons experience dyspnea toward the end of pregnancy. If there's an underlying pulmonary problem, the risks of right-sided heart failure are enhanced. The metabolic rate is greatly increased in pregnant women. I remember my husband complaining that sleeping with me during pregnancy was like sleeping with a furnace. As a result, pregnant women are much more likely to experience heat stress, heat stroke, and dehydration. I taught a dance exercise program for pregnant women during my second pregnancy, and the venue was not air conditioned. We had to cancel class every time the ambient temperature rose above a certain level. Now, a woman's weight may increase by 25 to 35 pounds in a normal pregnancy, but some women gain more or less. For those of you who have never been pregnant, this is like carrying around a 25 or 35-pound kettlebell all day, every day. Total weight gain may depend on whether they had maintained a healthy weight prior to pregnancy and can be more or less. Hyperplasia of islet cells leads to an overall hyperinsulinemia, and this is why pregnant women must eat regularly to avoid hypoglycemia. The lipid levels rise in response to insulin levels and estrogen. The pituitary gland enlarges and in rare instances can compress the optic chiasm and result in visual field cuts bilaterally. Pregnant women's levels of cortisol may also rise and may be somewhat responsible for the emotional liability that manifests in some women's pregnancies. Thyroid hormones rise because hepatic clearance is diminished. However, screening pregnant women for thyroid disease is not recommended by the American College of Obstetrics and Gynecology. Now, nausea and vomiting are common in early pregnancy. And in some women, the nausea and vomiting can persist into the 37th week of pregnancy. This can clearly complicate maintaining adequate nutrition and appropriate drug treatment. In addition, many women are extremely sensitive to smells. I remember in one of my pregnancies, I was working in general internal medicine, and I was the only provider on the staff who had any significant women's health experience. We had a young woman who had a lost tampon. And when I went in to remove it, the smell just overwhelmed me. So I removed the tampon, immediately went to the bathroom to vomit, and then returned to seeing patients. It isn't one of my best memories. Pregnancy also changes the metabolism and clearance of some drugs. So pharmacologic treatment in pregnant women must be managed with care. So pregnancy is also a state of glomerular hyperfiltration, which increases by 50% by the end of pregnancy. Plasma volume is up and renal plasma flow is increased, resulting in a drop in creatinine. Frequency and urgency are quite common, as is glucosuria. Spilling some glucose in the urine may be normal for some pregnant women, but should always be evaluated to ensure the woman is not developing gestational diabetes. Gestational diabetes can result in very large babies, over 10 pounds, fetal compromise, and is associated with a higher risk of diabetes later in life. Diabetic pregnant patients must be watched carefully and have their sugar tightly controlled to prevent complications for both the mother and the baby. In any event, it is important that pregnant women have ready access to toilet facilities, as urinary retention can result in urinary tract infection. The dilation of the ureters and the renal calcices increase the risk of pyelonephritis. And this is particularly true for women that have pre-existing diabetes or develop gestational diabetes during a pregnancy. So I was curious to see what OSHA says about the required location for sanitary bathroom facilities. So I looked it up. As far as I know, there is only this memorandum from 1998, based on evidence that urinary retention can result in urinary tract infections and low birth weight babies, that prescribes a clean bathroom facility should be within 1/4 mile from the work location. Medical studies also indicate that women void more than men, but I don't know if that little statistic changes with age and enlarged prostates. Some of the hematologic changes due to pregnancy are once again an increase in plasma volume by 30 to 50%. This means that pregnant women are probably carrying around an extra liter of fluid. The RBC mass increases due to an increase in erythropoiesis, but there's a relative anemia of pregnancy due to hemodilution. This hemodilution can lower the drug levels of many medications, potentially adversely affecting potency. The spleen increases in size by 50% of normal, and the body enters a state of hypercoagulation. A serious condition that can occur during labor and delivery is disseminated intravascular coagulation, or DIC, where all the clotting factors are hyperactivated and the clotting function eventually fails. This can result in severe hemorrhage and death. Hypercoagulation also contributes to the higher risk of thromboembolism during pregnancy. Pregnant women should actually get up and move once an hour or at least every 2 hours to avoid venous stasis. So when I started out in labor and delivery a long, long time ago, it was believed that during pregnancy, a woman's immune system was significantly compromised to avoid rejection of the fetus. And that is no longer believed to be the case. There is a very complex immune response that changes throughout the course of a pregnancy. Though certain immune cell functions at the level of the placenta may be suppressed to prevent rejection of the fetus, this is not true overall. However, it is also known that susceptibility to certain infections may be enhanced, and some infections are generally more severe during pregnancy. The increased risk of pneumonia, which was previously thought to be because of a suppressed immune system, is now thought to be related to the decrease in lung residual volume. During pregnancy, some autoimmune diseases worsen, like SLE, and some might improve temporarily, like RA and MS. This is most likely due to alterations in concentrations of certain types of T cells, B cells, cytokinins, and interferons. Now, this slide lists some examples of diseases that pregnant women may be more susceptible to, some which might be more severe in pregnant women, and some infections that pose a danger to the fetus. Many pregnant women develop an extreme sense of protectiveness for the fetus almost as soon as they realize that they are pregnant. And this might be expressed in rather extreme manners in some individuals. I remember working in labor and delivery during my first pregnancy. One night I was assigned to a patient with an active shingles infection. And even though I knew rationally I had a very high varicella IgG due to a severe chickenpox infection as a child, I asked the head nurse if I could be assigned to another patient. As I walked into the room of my new patient, I heard the resident say to her, "And when did you have this cytomegalovirus infection?" So as a pregnant woman, one sees hazards everywhere. Now, 90% of pregnant women experience skin changes in pregnancy. There may be a worsening or a clearing of facial acne, an increase in sebum production, or hair growth in new areas. These changes, in addition to a change in the contours of the face with the increased fluid load, may make being fit for and wearing respirators more problematic. 70% of women experience an increase in skin pigmentation, which is worsened by sun exposure. There is a condition called melasma, which results in a variegated dark skin pattern on the face. This condition could persist after pregnancy, especially if a woman's job involves outdoor work. Pregnant women who work outdoors should be counseled to wear sunscreen at all times. Pregnancy-related edema is common, as are the development of varicose veins and striae gravidarum, or stretch marks. Now, most visual changes in pregnancy are quite mild, transient, and don't require treatment. On the other hand, these changes can be severe, permanent, and require treatment. Glaucoma worsens in pregnancy because of the increase in intraocular pressures. The cornea thickens and becomes more sensitive. Some women can't wear their contacts during pregnancy. As the eyeballs swell with the increase in body fluid, pregnant women may notice refraction differences and may not be able to continue wearing their contact lenses as late in pregnancy. This might be an issue for jobs that require superior visual acuity and could contribute to an increase in trips, slips, and falls. Occasionally, as already mentioned, the enlarging pituitary gland can compress the optic chiasm and result in visual field cuts. This could be an issue for commercial motor vehicle operators and individuals working in other transportation and safety-sensitive jobs. Vision should be monitored during pregnancy if indicated by their job assignment. Now, pregnant women have a plethora of musculoskeletal complaints during pregnancy. Almost 50% of pregnant women experience low back pain from the increased lordosis resulting from an enlarging uterus. In addition, neck and upper back pain can result from engorged breasts and the need to hyperextend the neck with increasing lordosis. Joint pain and joint laxity due to progesterone and the release of relaxin, it's an adaptation to allow the delivery of a baby through the birth canal, is expected even in a normal pregnancy. The muscles, bones, and joints are carrying 25 to 35 pounds of extra weight all day, and strains are more likely. Peripheral neuropathies, including carpal tunnel syndrome, can occur due to edema, a direct result of the increase in plasma volume. I have very narrow wrists, and I could tell I was pregnant each time by the onset of the signs and symptoms of carpal tunnel syndrome. And pelvic pain at some point in pregnancy is almost to be expected. Unfortunately, treatment of these conditions is complicated by the side effects and teratogenic concerns associated with many pain medications. Aspirin and nonsteroidal anti-inflammatories may increase the risk of bleeding in pregnancy, and there are even some concerns about the use of acetaminophen and associated neurological complications in a newborn, although I think most of those have been disproven. Acupuncture and exercise remain the mainstays of musculoskeletal pain treatment during pregnancy. Now, pregnancy can be a time of significant emotional and psychological growth. I have known women who felt more productive, more creative, more energetic than ever before in their lives. As a basic type A person, I loved being pregnant because I was doing something important even when I was sitting still. However, psychological ambivalence is quite common even among people who planned the pregnancy and are looking forward to parenthood. Pregnancy does alter one's body image. I recall looking in clothing store windows and wondering if I'd ever have a waist again. The massive neuroendocrine fluctuations of pregnancy can have both positive and negative effects. Emotional liability is a hallmark of pregnancy, as is the fear of the unknown and the feelings of profound vulnerability. Extreme stress and anxiety, whether it be related to work, family issues, financial problems, or marital discord, is known to have deleterious effects on the fetus. So be very liberal with your use of EAP referrals with your pregnant women when indicated. Finally, a word about the pharmacological considerations in pregnancy. Most pregnant women have traditionally been excluded from clinical trials. Results and dosage levels determined from studies with non-pregnant individuals cannot always be generalized to the pregnant patient. Nausea and vomiting can lower drug levels of necessary medications. Some drugs are metabolized more rapidly. Some end up with actually longer half-lives. Keep in mind, if you're prescribing medications to a pregnant woman, you are prescribing for two. In terms of birth defects, the timing of any drug exposures is paramount. I make it a habit to check with an OB or a pharmacist when prescribing a drug to a pregnant woman. So in summary, why are the physiologic changes in pregnancy relevant to the workplace? Keep in mind the following. Body levels of toxins are higher at lower levels of exposure. So OSHA and NIOSH RELs and PELs may not be relevant. Personal protective equipment may not always protect both the mother and the fetus. Pregnant women may be more susceptible to certain diseases, and other diseases can adversely affect the fetus. The shift in center of gravity affects balance and increases the risk of slip, trips, and falls, and can result in a plethora of musculoskeletal complaints. Metabolic changes affect blood glucose levels, hormone levels, medication action, and clearance rates. Renal changes increase the risk of UTIs, kidney infections, and make voiding frequently important. Joint laxity also contributes to slip, trips, and falls, and muscle and neurologic problems at work. And visual changes may or may not affect work, but an alteration in vision also contributes to slip, trips, and falls and could endanger others if the woman is expected to have superior visual capacity for a particular job. For example, if they're a histologist, an air traffic controller, a driver, a police officer, etc. So we're going to switch gears now and talk about the pregnant woman at work and the law. Knowing the law is important in occupational health because suits related to pregnancy discrimination are one of the fastest growing legal disputes today. The US has a very long history of pregnancy discrimination. In 1908, women could work no longer than 10 hours a day because they also had to fulfill their maternal duties. Men were allowed to work longer. Up until 1970, pregnant teachers were not hired or were not allowed to continue to work when they began to show because children might be distracted by the visible signs of pregnancy. They were also not able to work in what were considered high-risk jobs. In 1974, exclusion of pregnant women from the disability system was deemed non-discriminatory in California. It was not until 1978, with the passage of the Pregnancy Discrimination Act as an amendment to the Civil Rights Act of 1964, that pregnant women had rights to the same pay, same leave, and same general protections as any other employee with a disability. In 2002, California extended unemployment benefits to parents taking leave for pregnancy or childbirth. In 2014, the Pregnancy Discrimination Act was amended to cover the entire childbearing couple. And in 2015, the opportunity for accommodation was open to all, including pregnant women, if they were a qualified individual and had a specific disability. But pregnancy itself was actually not defined as a disability. Pre-2023, there were a number of laws relevant to the pregnant worker. I won't go into detail on all of these because if you've worked in occupational health for any time at all, you'll know more than the average clinician about all these laws. However, before this year, pregnant women still had to prove they had a disability in order to qualify for reasonable accommodation or pre-delivery leave under the Family Medical Leave Act. Now, this slide summarizes the requirements of the Pregnancy Discrimination Act as amended in 2014. Generally, job actions cannot be based on the presence of or the possibility of pregnancy, and both members of the childbearing couple are offered the same benefits other than those related to pregnancy, delivery, and recovery. Now, keep in mind that almost all countries around the world offer some type of paid leave following the birth of a child. The United States is one of the only developed countries that does not federally mandate paid leave for pregnancy, although there are some states that do. A recent study in obstetrics and gynecology linked paid leave with higher rates of breastfeeding, which we know is very healthy for the mom and the baby, and lower rates of postpartum depression. My daughter works for Dannon Yogurt. It's a French company, and they gave her 6 months of paid leave after the birth of each of her 2 children. They shut off her email and did not bother her that whole time. Now she is a senior director for Dannon Yogurt. When she returned to work, she managed the logistics of importing European baby formula to ease the US shortage. It involved working with the White House on policy and tariff laws, the loading and scheduling of US Air Force jets, finding the proper storage facilities, and overseeing distribution in the US. They had a pretty motivated worker there. I don't know too many other pregnant workers that had such a positive experience, including myself. In 2023, a step forward for moms working for US companies occurred with the passage of 2 laws. The Pregnant Worker Fairness Act and the PUMP Act or Providing Urgent Maternal Protections for Nursing Mothers Act. Both were signed into law in December 2022 as part of the Omnibus Spending Bill. So what does the Pregnant Worker Fairness Act offer pregnant workers? The PWFA prohibits employment practices that directly or indirectly discriminate against a worker who is affected by pregnancy, delivery, or what are called pregnancy-related medical conditions. We'll talk about those a bit later. It prohibits requiring the worker to accept an accommodation that was not subject to the interactive process, and prohibits denying employment based on the need for reasonable accommodation. I don't know of any lawsuits yet, but I suspect this law either already applies to fathers and domestic partners or will in the near future. The PWFA also prohibits requiring the employee to take paid or unpaid leave if another accommodation is available, and it's unlawful to take an adverse action against a qualified employee, i.e., you can't change the terms of their employment, you can't demote them, you can't terminate them, because of the employee's reasonable accommodation. The PWFA also prohibits retaliation for needing, requesting, or using an accommodation. An employee cannot be forced to accept an accommodation the employee does not want or need, take leave, paid or unpaid, accept a reduced work schedule, or stop traveling for work if they don't want to do this. Workers now have the freedom to request accommodation for a wide variety of pregnancy-related conditions. This is a major legal change. We'll talk about a number of pregnancy-related conditions in the next few slides. Employers cannot require any special language in the reasonable accommodation request, must respond to the reasonable accommodation request immediately, and even if the worker cannot do all the essential functions of their position, they are eligible to receive a temporary reasonable accommodation throughout the childbearing process. The PWFA applies to federal employees, employees in the private sector in companies that have 15 or more employees, full and part-time workers, seasonal workers, temporary workers, and job applicants. Now, I'm sure some of us as occupational health professionals are groaning and thinking about the workers in your facility that might take advantage of these new laws in ways that seem out of control. But keep in mind, some pregnant women, probably the majority, won't need or ask for accommodations. On the other hand, I'm aware of a situation at a facility that will remain nameless, where a pregnant woman didn't say a word about her pregnancy to anyone, began to take longer and longer breaks, used all of her leave, continued to be absent even without any accrued leave time, and refused to lift anything. The providers were beside themselves because it was as though they didn't have any support staff at all. She didn't officially tell her employer she was pregnant, and she really didn't have to as her girth increased. But someone at the facility knew she was pregnant early on, and her boss and human resources were afraid to do anything for fear they'd be in violation of the law. They set a very bad precedent. She interpreted the law to mean she could do anything she wanted and still have a job. I'm not quite sure what this company can do after the delivery because the law prohibits any retaliation for pregnancy-related accommodations as well. It is very important that your company and HR department establish a policy related to the Pregnant Worker Fairness Act and sit someone like this down and talk about what's happening. Pregnant women are still employees and should abide by company policy. The pregnant woman's rights should be reviewed and expectations should be clearly set to maintain adequate productivity. Communication is key. This is a situation where a formal interactive process is essential, and the pregnant woman must continue to communicate with the employer when she's going to miss work or can't handle certain aspects of her job. All discussions of accommodation should be carefully documented. You don't ever want an employee to accuse you of not initiating this sort of interactive process. Now, as an occupational health professional, I know some of you are groaning about this new law and potential complications presented, but uniform federal protections can actually lead to clarity in HR offices, less turnover, boosts in employee morale, and improved public relations, all of which can decrease costs and keep a business running smoothly. Now, the second piece of legislation related to childbearing to become effective in 2023 was the PUMP Act, or the Providing Urgent Maternal Protections for Nursing Mothers Act. Nursing mothers are now guaranteed reasonable break time to express milk for their newborn, and the timing of this breaks must meet the needs of the mother and the baby rather than the desires of the employer. The employer must provide a place to store the breast milk. This law will not apply to the airlines, commercial motor carriers, or rail employees until at least 2025, and airlines may not be included then. This remains to be seen. Undue hardship exemptions still apply, and this may be why the industries above were not included in the original legislation. The pumping location supplied by the employer must be not a bathroom, sanitary, have sanitary appropriate storage facilities for breast milk, must have a place to sit, must be shielded from view, and must have an electrical outlet. I breastfed both of my daughters, and I would have appreciated such a place. The bathroom wasn't private enough, and I worried constantly about the contamination of the breast milk. So let's move on to the most important part of this presentation. What kind of accommodation for the childbearing employee are reasonable? Determining what you can do as an employer may depend on what kind of industry, how many other people do the same or a similar job, how long the accommodations will last, and whether the accommodation will extend through the postpartum period, and whether undue hardship is an issue. Every situation will be unique, and every request and situation are legally subject to the interactive process. Now, general accommodations for a typical pregnancy are listed here, and they might include extra breaks for rest, snacks, water, and restroom use, new uniforms as the body size changes, changes to job duties or work location to reduce or avoid bending, lifting, climbing, walking, or prolonged standing. This might also include a temporary change to the parking location, the ability to drink water and eat during the workday, schedule changes or excusal from absence and tardiness policies, time off for prenatal care, leave prior to childbirth, and 6 to 8 weeks after birth. Now, depending on the industry, there may be more toxic or hazardous conditions that the pregnant worker will request accommodation to avoid. Listed here are possible accommodations to prevent toxic exposures, heavy lifting, extremes of temperature, long work hours, or rapidly rotating shifts, or increased risk of slip, trips, and falls. Remember, the employer cannot insist that a childbearing individual accept a particular accommodation, but these are suggestions for accommodations that can be brought up in the interactive process. Industries with high toxicity risks are agriculture because of the pesticides and extremes of temperature, manufacturing because of heavy metals and solvents, beauty parlors, dry cleaning establishments, and custodial and cleaning services where exposure to solvents and other hazardous chemicals are very common, and healthcare with possible exposure to hazardous drugs, infections, heavy lifting, and radiation. I'm going to go through the next few slides fairly quickly. Listed here are fairly common pregnancy-related medical conditions and possible accommodations. Things like pregnancy-related anemia, an increased risk of gallstones, migraines, deep vein thrombosis, edema, dyspnea, carpal tunnel syndrome, fatigue, and reflux are pretty common. Listed here are also reasonable accommodations. This table and the 4 to follow were adapted from the website listed at the top, www.pregnantatwork.org. And I would suggest you take a look at that because there's a lot of really wonderful information there. Hyperemesis gravidarum is also very common. I remember with my second normal pregnancy, I was vomiting so much I couldn't catch my breath, and I was afraid I might choke. I called a friend to have her sit with me so she could call an ambulance if I did choke and aspirate. The pregnant worker may develop gestational diabetes with an increased risk of both hypoglycemia and hyperglycemia. You may be dealing with a high-risk pregnancy or something as simple as hemorrhoids. You may encounter a woman at high risk of preeclampsia or one exhibiting intrauterine growth retardation. Preeclampsia, which is also called toxemia, develops after 20 weeks of pregnancy and is characterized by high blood pressure and severe proteinuria. Peripheral edema is part of the syndrome, but this is often hard to distinguish from the edema associated with a normal pregnancy. Preeclampsia can lead to hypertensive crisis, renal function compromise, liver failure, seizures, and even death. But 60% of the deaths due to preeclampsia can be prevented by early recognition and intervention. Your pregnant worker may be suffering from a number of musculoskeletal disorders. Lower back pain occurs in more than half of pregnant women. The most affected musculoskeletal structures are the pubic symphysis and the sacroiliac joints. Non-inflammatory causes of back pain resulting from bone marrow edema are difficult to differentiate on X-rays from axial spondyloarthritis. The individual may be pregnant with twins or even triplets. She may be experiencing oglahydramnios, which is a low level of amniotic fluid for gestational age, or have abnormal bleeding or a low-lying placenta. She may have an incompetent cervix and be at risk of preterm delivery. Or she may be struggling psychologically. As mentioned earlier, there are infections that tend to be worse in pregnancy and put the fetus at risk. Or the pregnant worker may have any of these pregnancy-related conditions. With my first pregnancy, I was working in a very busy labor and delivery unit, and we had 16 deliveries in one shift. I didn't take a break to eat because we were just so busy, and I literally passed out from low blood sugar. I actually made things worse by trying to be a superwoman. This list is in no way exhaustive, but it gives you an idea of what the pregnant person may have to deal with. Our job is to support the pregnant woman and the childbearing couple while acting as a consultant to the employer to prevent legal liability and maintain workforce capacity. Having happy, healthy childbearing employees and healthy babies bodes well in the long run toward all of the above. Now, before we leave this subject, I'd just like to point out one more role for the occupational health professional, and that is to act as a consultant to primary care providers and possibly even HR, but particularly to the primary care providers that are writing work notes for their pregnant patients. Listed on this slide is what we tell primary providers about writing these notes. We've all gotten notes that say no exposure to any toxins or no lifting. These phrases will not help in developing a reasonable accommodation. At the same website mentioned before, www.pregnantatwork.org, is a handout that can be shared with primary providers to assist them in writing duty status notes for their pregnant patients. In addition, there is a link in the resources section of this presentation to a work accommodations note tool, which can be shared with primary providers. It provides language and structure for work accommodation medical notes. I will just say one more thing about this, and it's important that you talk to your HR department about just generally having a policy that work accommodation notes should always have an end date on them, a start date and an end date, if at all possible. If it has to go on forever, then it has to go on forever. But work notes that identify restrictions should always have a start date and an end date, because your work-related pregnancy notes must have a start date and an end date, or a review date by the primary provider or the obstetrician. I would recommend that you make that very clear to your pregnant patients and do that for all your employees. because you don't want to treat your pregnant patient any different than the rest of your employees. So these are the references I utilized for the presentation, and here are some more, and here are some resources that may be helpful, and some more. And I would like you to thank you for your attention. This is my second daughter. If there's any questions and we have time, fire away. But this is what we're working toward: a happy, healthy, and productive childbearing couple with their healthy baby.